Let me briefly restate what we've just talked to elected officials about. About 2 weeks ago, it became apparent that we were having difficulty transitioning or transferring people into Kansas City from outside rural hospitals. And as chief medical officers, we've been meeting on a regular basis, usually by Zoom call 1, 2, 3 times a week. And that's been going on since late March and early April. And that's the chief medical officers from all the hospitals here in Kansas City. We just finished our presentation to the elected officials when 6 of the chief medical officers from different hospitals hosted those elected officials. And that included the CMOs from Liberty Hospital, Raghu Adega, Jim Stewart, the CMO at North Kansas City, Mark Steele from Truman Medical Center, Peter Holt from St. Luke's Health System and St. Luke's Plaza, and Larry Bott from Advent Shawnee Mission, as well as David Wild and myself. The message that we gave was one that was that the hospitals are concerned about capacity, because historically the data that has been reported and been taken out of what's HHS safe or whatever the right phrase is that looked like we had 2,000 open beds that for general medical patients and about 300 ICU beds. But when we heard that we couldn't staff patients or couldn't take patients from outside communities into Kansas City, we became very concerned. So we had a call with the CMOs, and it became readily apparent that the number of staffed and available beds that could be used, that is, beds that had the resources around them, that a patient could be taken care of them, was much different than the number of physical or licensed beds in hospitals. And that's because there's a staffing shortage. And that staffing shortage is not going to go away anytime soon. So we have to work off the number of staffed beds that are available in our community. In doing that, we worked with all the CMOs to work with the hospitals and said, hey, what are the number of staff beds? And so the CEOs and the CMOs worked together, and we're developing a new dashboard that will show the number of actual hospital beds that can be resourced and staffed, and therefore we can put a patient in safely. And I'm going to turn to my colleague, David Wild, our VP of Performance Improvement, who's great with these numbers. David, that difference was not insignificant.
It is very significant, actually. And so part of the story that we're telling here today is this kind of concept of the difference between what might be recorded as licensed beds and a publicly available number, a handful, actually, of different definitions of what staffed beds might mean. And then even further, this distinction of which beds that can be staffed are actually able to take care of patients who need medical care, adult patients who need medical care or surgical care. And so let's maybe start at the beginning. The licensed bed number actually doesn't mean a whole lot operationally. And there are a number of reasons for that. And it's not actually really an important part of this conversation. And actually what the federal government has been asking for healthcare facilities to submit in the sense of data is a staffed beds number. So staffed beds are the number of physical locations we have that we can fully resource with all the human resources necessary: nursing staff, medical staff, respiratory therapists, pharmacists, all of the people that are necessary to provide care. That's a staffed beds number. And operationally, that changes throughout the day multiple times per shift for a number of reasons. But there's also another definition of staffed beds that has provided some confusion we've learned throughout this process. In some states, Missouri being one of them, not quite the same story in Kansas, but on the Missouri side at least, a staffed number is required to be quarterly reported to the state, which you sort of budget and plan on, not what you can physically staff today. And the physically staffed today number might change based on the number of ill employees, the acuity of patients, any number of other factors. And so licensed beds really doesn't play a part in this conversation. Physically available beds is an interesting part of the conversation. Those beds that are available right now to staff a patient, to take care of a patient if staff didn't matter. That tells us if something like a field hospital would help, for example. If we were out of physical beds and had staff, then a field hospital might be an option that would provide some different sort of relief. And then there's the staffed bed question. And so that information we have been presenting today and really talking with a number of our elected officials about over the course of the last week or two is that staffed number across the metro, what we can staff this shift. And that snapshot is what we're describing really as being concerning at this point in time.
I think it is a concern, and that's the message we're conveying. And so, do you have some numbers you want to share from that one day that snapshot in time?
Sure. So this is a snapshot from Tuesday of this week, so Tuesday the 3rd. And it's looking at the physically available number of beds that can be used for adults. So this doesn't include nursery beds or NICU beds or behavioral health beds or any other bed that can't be easily converted into a place where we could care for an adult who would be needing medical care, whether that be for COVID or something else. And so that number on Tuesday was 153 non-ICU beds in about an 11 hospital sample of the metro. And about 76 of those beds, non-ICU beds, could be staffed on that Tuesday. I'm sorry, 153 non-ICU beds, 76 ICU beds physically available. So 153 non-ICU beds. I'm confusing myself. 153 physical non-ICU beds, 76 that could be staffed. 32 ICU beds physically available, 22 that could be staffed. And that's a significantly different number than shows in a federal government HHS database, for example, that's talking about total available beds, which would include nursery, NICU, PICU, all of those things.
And those aren't available, and we don't have the staff to run them, even if that's true. There's only a few places that are able to staff, and we're very fortunate we're able to staff every one of our physical or licensed beds, or not our licensed bed, our physical beds that we can use. But the struggle is that throughout the community, when we try to go get agency nurses or travelers and things like that, we're all trying to borrow from the same pool. And as CMOs, we recognize that's not the best outcome. But the real crunch is that there just aren't enough beds available. And when you get in that situation, you have to go back to the pillars of infection control and say, what is it that helps prevent the widespread community transmission of COVID-19, which is where we are right now. There's widespread community transmission. And so the answer is, it's the pillars of infection control. The only other way for hospitals to create capacity to handle those patients is to start thinking about canceling elective surgeries or slowing things down again. But it's not the same day surgeries that matter, because they don't come into the hospital. They get the surgery and they go home. This is not a PPE question. This is a bed capacity question. The only way you can do that is to cancel what is called elective surgeries. What I would say to you is that that's a terrible term, because those patients who come in the hospital and have to stay are often people who have cancer, people who have heart disease and need open heart surgery, patients who really need a hip replacement or a knee replacement. These are not patients who you really think are truly elective. You may try to delay their care, but that delay in care could cause harm. So at that point, now you're trying to make a decision between what group of patients are you going to take care of. And our point to our elected officials today is that we're a little concerned about where we are on that, because the rapid rise in Kansas City, I mean, at kansascity.com, you can go see the data. We're over 300 or over 700, our rolling 7-day average is 700 new patients a day. That's a concern. On Monday of this week, when the CMOs from the 6 hospitals that have reported their data to us every single time on this call, back to April, had their data, we had 277 COVID patients in our hospitals. Today, we took it on the call. Just a few days later, we're at 318 and climbing. So the rate of rise is rapid, and we are concerned about that. And we don't want to turn it into one of those communities that's totally overwhelmed. And so that's our message out there, is that the data you've had isn't the real boots on the ground. It's not real time. We're showing you the real information. Here's what it is. Now let's try to make decisions together about how we're best going to handle our healthcare resource, because it's a much narrower supply than we thought. So with that, let's have questions.
Lindsay from 41 here. What are the
Hey,
steps
Lindsay.
you're taking right now? Have you reached capacity? Are you taking any actions today because of what you're seeing?
We're taking actions today to try and work with the community, obviously, to work with elected officials to see if we can help reinforce those rules of infection prevention and control. I mean, we had a question on our morning media show program this morning. What's the one thing people could do? Who can really help us stop it? And the answer is you, not you per se, the media, but every individual are the ones with their personal actions that can do the best thing. The next thing we're doing is trying to think about is who we could try to delay surgery on. We don't want to do that, because that is not a good option. So staying in our lane, we're trying to stay right there. All right. And hey, so we have this, we had a little trouble getting the chief medical officers back on the line. So the last question, guys, they're on with us now. And so I'll call to them individually as we go through these questions. The last question is, what are we doing to try and help with bed capacity? And I'll turn, Peter, do you want to take that one on as well? Peter Holt, CMO over at St. Luke's on the Plaza. Peter, don't forget your mute button. All right. If we don't hear from Peter, let's turn to Larry Botts. Larry?
Well, doing the same things that you elucidated there. We're looking at in the future what kinds of things can we not really cancel, but delay if we need to make those beds and that staff available. We're looking at stretching as much as we can, having some of our nurse leaders who don't usually take a full load of patients when they're here to stretch that and be able to staff more beds. We're continuing, as everyone probably is, which is to look at contract nurses, which are difficult to find because obviously everybody's looking. So right now, those are the things we're doing. We're able to continue to take care of our patients, both the COVID and the non-COVID. But as everybody else has said, we're at a level that may make us move to that next step. But those are the things we're looking at.
And that's a tough level, because at that point, it is that we are choosing between who we're going to give care to, right? That's the choice, because these are not patients. You can really say, well, you don't need to have that surgery. Well, actually, no. For people that are going to have to be hospitalized, they almost all need surgery. Yeah, it's not easy.
And if I put my anesthesiologist hat on, right, and think about how many patients a day across the metropolitan area need to be admitted after an elective surgery. It's tiny, right? There are plenty of people that get admitted for a non-emergent surgery related to cancer or some other condition, right? An irregular heartbeat or coronary artery disease. It's not emergent in that we ran you right to the OR from the emergency room, but it's definitely not elective. There are not elective surgeries that require admission to the hospital. We do so much outpatient elective surgery now that elective surgeries are not the issue. They just aren't.
Yeah, and those patients don't take up the hospital beds we need for COVID patients. The thing that we need for COVID patients, and just to say that, at least at our institution now, COVID is the leading admission diagnosis. I mean, a year ago, there was nothing, and now it is the leading reason to come in the hospital. Not cancer, not heart attack, not heart failure, not COPD or emphysema. The number one reason is COVID. Well, that's a big change for us, and we're headed right smack into the cold and other flu season, et cetera. And we know this is always when hospital capacity is stretched. It's not unusual for us to be full this time of the year, but now we've got 10 to 15% more patients from just one disease. Next question.
This is Abby from KCTV5. I was wondering, how are you guys prioritizing patients? Is it age? Is it people in the Kansas City area? I know you talked earlier about difficulty transferring people in from rural areas. Can you talk us through that?
Yeah, so that's a great question. We try not to prioritize. We try and take care of everybody. That's our goal. But I think that's also the struggle. And I know, David, we've been having to turn down more people on the transfer center because we didn't have beds.
Yeah, it is a great question. And I think, we're not at the point where we are making decisions about people who are truly in an emergent situation in an emergency room or in a small hospital that doesn't have an ICU, for example, and prioritizing based on age. So I think that's a great point to make. We're not saying, boy, if you're over a certain age, you're not getting care. Not at all. Instead, the decisions that we're having to make are more along the lines of, wow, do you absolutely need to be here right now? Do you need to be in our hospital right now? I think everyone is sort of fighting that battle, asking those questions, which are kind of hard. We all like to say, if someone calls and says, we need to send a patient to you, we all like to say, yes, we're here to help. And so the prioritization now, I think for all of us, and others can chime in, is more related to, do we have the space? And can we offer something that the place you're at currently cannot offer? And that's really the decision at this point.
And the problem is with rural areas, especially, we can feel that pinch. So I don't know. Hey, Peter, are you able to join now? Peter Holt from St. Luke's, are you on? Okay. So what we know is that for those who have a more extensive rural network, that's get hard. So let me turn to Raghu Adega up at Liberty. Raghu, you've taken a lot of people from northern counties in Missouri into Liberty, but as these numbers rise, your ability to do that is going to become limited.
Yes, I mean, it is always a concern, and the main thing that we look at is, capacity and capability when we have questions like that come up. And we certainly don't want to say no to any of the rural emergency rooms who have a critically ill patient who really needs the care that's not available in their hospitals. However, if it is not that issue and we really do not have the capability, and we look at, the details, the transfer center does look at the severity of their illness, and they have a communication with the accepting physician to figure out, is there something that we can do to accommodate to get them in here? We never refuse anybody who's on their way to the emergency room. The ambulances are not turned back. So we'll be taken care of.
All right.
Sorry about that.
Okay, I think we've got it under control with the mute button. All right. Is there another next question?
I'm sorry, just to summarize what you guys are saying, you're saying local hospitals are not yet at capacity, but if it continues like it is, they will reach it very soon to the point you have to consider canceling elective surgeries and not accepting patients from outside communities. Is that right?
Yeah, I think that's exactly right. I think you've got it. I think that we're trying not, because we think that that's not the right thing to do to care for patients. But our fear is that a current exponential or nearly exponential rise in COVID-19 on a rolling 7-day average and the increasing number of COVID patients in our hospitals is suggesting to us that we're very concerned. And so our message is we're really concerned. We're not saying it's a crisis. We're not panicking, but we're just saying we're concerned. We're trying to get that message out so that people can start doing a better job of following the rules of infection prevention control. One of the stories is this: what's the hottest spot in any community, right? It's true, I don't care where you are in the world. What's the hottest spot? And the answer is, it's the hospital. The hospital has the biggest focus of COVID patients, right? Because we all cohort the COVID-19 patients. And that's the hottest spot in any community, are the hospitals themselves. Now ask the next question. How much spread do you see between patients and your staff? And the answer is, we don't see it. So why is there widespread community spread, or widespread community, widespread spread, that's not the best term, but widespread transmission of this disease in the community, but in the hospitals we don't do it? Why do we not spread it? And the answer is, infection prevention and control works. Masks work. If you do the right thing, you can stay safe, and that will then keep all of our community safe. And I think that is a really important lesson for us all. We keep hospitals safe. It's up to every individual to help keep our community safe. Next question.
This is Kelly Eckerman. So you just bring all of those elected officials. Are you recommending a call for lockdown based on what you just said?
Okay, so I'm not sure I understood that, but what I think it came out, I'm just going to answer what I think came out. Are we recommending more, I assume it's sheltering in place and things like that. And that's not our job, right? Our job is to let people know as CMOs, this is what's going on in the hospitals. I think it's up to the public health officials and publicly elected folks to balance the equation of what they see and what we're telling them with the economic hardship and the economic reality. We don't see that side of it as much, so we're going to focus on staying our lane around that. What we do know now is that if people can wear masks and stay healthier, we're going to have a better job of keeping businesses open. So I think that, to me, those questions those 2 points can coexist. They are not necessarily oppositional. And I think what we have to remember, though, is it's really about trying to do the best thing we can. If we do that, we can both help take care of all our patients, take care of all our folks, and keep the community open.
Are any of our local hospitals currently turning away ambulances right now, or beginning to create a contingency plan for if they do not have room?
So we have a contingency plan. So let me ask, I think Mark Steele over at Truman Medical Center. Mark, are you guys having to turn away any hospitals, and do you have a contingency plan if this crisis were to worsen?
Yeah, so fortunately, currently, we are not having to turn away any patients, and we're able to accept ambulances. And of course, we do have a contingency plan in case things get worse.
And Jim, how about North Kansas City? It's Jim Stewart. I thought I saw. Jim, are you there?
Yeah, Jim actually did send a message. He had to drop off for a capacity issue question.
Oh, well, there you go.
So.
So I think we're all trying not to do that, David, but I know that sometimes the emergency rooms can be full.
Yeah, I think there are some interesting distinctions. Much like really the entirety of our conversation today, there's nuance in those circumstances. So if an ambulance is on a way to an emergency room with a patient who truly is in extremis, right, who needs emergency care for a condition like a stroke or a heart attack or a trauma, and they need to stop at the closest hospital, even if we're unable to take less emergent for some reason, less emergent ambulance transfers into our emergency departments, those truly emergent patients are coming. And so that level of triage happens on a regular basis. Are we turning away a lot of patients who have a hip fracture? No, we're not here. I know that there have been stories of those sorts of things happening across the metro, and others may want to comment, but it's not a regular practice to turn away ambulances, really, and we're not at a point where we can't take another emergency patient. So the same is true through the transfer center, as I described. If a patient is in an emergency room and really needs intensive care in a place that doesn't have an intensive care unit or has no more intensive care unit beds or no more ventilators, those patients we're able to manage right now. But the concern is if this continues, we might struggle. And so yes, that's sort of where we find ourselves. And yes, we all have contingency plans.
And there are reports of rural hospitals having difficulty finding places to take their patients. And again, we've been trying to accept them, but we know that there are times we've not been able to take another patient in.
And it's very true that many rural hospitals, and I know that those others on the line who have these same problems can chime in as well, but there are rural hospitals that are calling us to accept transfers that are 4 or 5 or 6 hours away that don't normally call us because it's really sometimes challenging, if not unsafe, to take a critical patient 6 hours in an ambulance if they can't fly, or if there's a reason that ground transport must happen, or even the time and logistics it takes to get a rotary or a fixed wing transport to a hospital. So we don't normally get calls from those hospitals, and we're getting calls from them every day. We're getting calls from states that we never get calls from. So yes, I think there are rural hospitals we know that are struggling with their normal referral patterns, that have reached their contingency plan, that are asking for help. And those things are increasing, but they're not hundreds or thousands of patients or calls. That's not really the big burden for us at the moment. The big burden are those in the metropolitan area who continue to need hospitalization for a number of reasons.
Next question.
Hi, this is Emma James with 41 Action News. You guys spoke about how you're not panicking right now. We're not at capacity. We're not at that moment right now, but we are getting extremely close. Can you kind of give more details on time frame for how close are we? When could we maybe expect to be at that point?
Yeah, I don't know that I'm comfortable giving a time frame because the problem, there's so many variables out there, and we've been fooled before. We thought we were going to have a horrible crisis back in April, and we were able to avoid that. Then that because people can pull levers, and we could cancel electives, and things are not electives, these surgeries with admissions. We can do things to try and help prevent the crisis. What I can say to you, though, is if widespread community transmission continues to go up, we will be overwhelmed. That is the inescapable conclusion that we face. I don't know, but I can't put a time number on it because, again, there's too many variables. But as people move inside, we move through holidays like Halloween, but really Thanksgiving and Christmas, and people are getting closer together. That's when transmission is going to happen. And I think that's why we got to get the message out, folks. We don't want to have you not be safe or be able to get a hospital bed. And the way to do that is to follow the pillars of infection control. That's what bends the curve, right? We've bent the curve before. I'm a native Kansas City, and I'm born and raised here. Went to McCoy Elementary School in Independence, Missouri, and went to Truman High School and William Jewell College. You know what? We can bend the curve. This is Kansas City, but we're going to have to take a lot of action now.
Yeah, and maybe I'll jump in. I agree. I can't tell you if I can't pick a date that we're saying we would be really in a dangerous capacity crunch. But what I can say is if the trend continues that we have seen over the past week, we're talking not months. This is not months away. This is not an unurgent conversation. Is it tomorrow? No, I don't think so. Could it be? Well, maybe. But it's more likely weeks.
Well, in fact, if you look at the data in El Paso, they went exponential over 2 weeks and went to their COVID census. I think it tripled or quadrupled in 2 weeks time. So, that's what can happen when you have widespread community transmission. That's what happens when people aren't following the rules of infection prevention and control. That's what happens when people want to act like it was before COVID. Those things are not true. We've got to make them untrue. We've got to follow the rules of infection, because again, coming back to the hottest spot of any community, it's the hospital. But we don't spread the disease in the hospital. Why is that? Mask, hand washing, distancing. It works. Next question.
This is Abby from KCTV5. Of those people in the hospital with COVID currently, how many are reinfections or patients that had to be readmitted because they're having problems with their heart and their lungs?
Yeah, great question, Abby. We don't see that many reinfections yet. And we do track that. That's a relatively unusual occurrence. I think we've had maybe one or two.
A couple maybe patients and maybe one employee that we think it's likely.
Yeah, but then there are people who do come back in the hospital with heart disease or worsening lung disease and things like that, and they're not necessarily infectious at that point, but they are sick, and so they're COVID-related admissions. And so if you look at our numbers, the number we have today was 55. But we have 28 patients who are in the hospital and have been here more than 10 days. Some of those could even be readmissions, but even the readmissions are a relatively unusual recurrence compared to the number of COVID patients who are freshly admitted. Next question.
Yeah. I know that you said that it's not your job to decide if there should be lockdowns or mandates or anything like that, but with all this that have to believe somebody asked what your advice was, what was your overall message to all of those elected officials?
What is the overall message?
Yeah, I think that's So let's talk. We'll throw that one around a little bit. Raghu Adega is an infectious disease doctor in the CMO at Liberty. Raghu, what would you say? What's the overall message for what officials or what public members of the public can do?
Yeah, obviously, it's very difficult to tell public officials what kind of policy measures they should be taking from the physician's perspective, but we can still stress on the importance of infection control measures that you talked about and making sure that that is widespread. There are some smaller rural communities where mask wearing is not as common as it is in other areas. So that is one area. And of course, I think we want the public, elected officials to speak more, just like how we do in terms of bringing in the importance of avoiding these small family gatherings, small community gatherings. That's where the spreading is happening. And then, of course, we do have holidays coming, and obviously those gatherings are going to create a lot of stress. So we want to make sure that we all speak in the same voice. What we CMOs are saying is pretty much the same as what the CEOs are saying and what the public health officials are saying and the elected officials are saying, so that the message gets across to the public. And as Steve mentioned earlier, it is all with the individual people that they have to be cognizant of what they're doing in preventing this community spread. So the more we have everybody speak the same thing, we are not necessarily talking about any individual measure we want the community, the public, elected officials to do. We're not saying you go, close down this, close down that. That's not what we're talking about. So,
Larry, for what your perspective, what would the message be that you would give to say this is what we need to do?
Yeah, I agree with Raghu. I think that, what we need to do is emphasize the fact that the rules that we have flattened the curve in the past. If we can continue to adhere to those infection prevention, I think to his point as well, those social gatherings, whether it's with family or not family in indoor areas that's crowded and people not wearing masks, those are the kind of events that are most likely to result in difficulties. And so those are the things that I think we want to try to emphasize, that if we can minimize those kinds of situations, that we're going to do a whole lot better with trying to keep that disease in check.
Mark, thoughts from Truman?
Yeah, so I agree with my colleagues, and I think it's all about getting everyone, I mean, all leaders to speak out about this and to emphasize the importance of following these infection control recommendations and anything, quite frankly, that we can do to improve compliance, the better off we're going to be.
Yeah, I think that's really the key, isn't it? The more we can do that. I mean, I think what people would want us to say is, well, close all the bars, close all the restaurants, shelter in place, no, close all non-essential businesses. That is not our job, right? That we're not going to say that. What we're going to say is, if you're going to keep things open, do it safely. We know how to do that because it does work, and we've shown that it can work. We've bent the curve doing that before. We just need to get back to that point. So next, two more questions.
This is just to clarify, not necessarily a question. This is Abby from Channel 5. So what you're saying as far as capacity goes, it's kind of twofold. It's the increasing rate of COVID-19 in our area coupled with the staffing capabilities at every hospital, correct?
That's right. That's exactly right. And the third layer to that is our elected officials had information prior, and this is true around the country, unfortunately, and it's just a vagary of how HHS has reported the data. But they've been acting on information that showed them that there was not a shortage of beds. And today, and over the last few days, we've been sharing with them that there is a shortage of beds and we're running low. And that's a different message than what they've, so in fairness to our elected officials, they just got that message. And now we're trying to make sure the public knows that message is because we don't have a lot of beds left in Kansas City. And we want folks to help us bend the curve. More questions.
This is another clarification. I know that you gave us some numbers earlier. Were those numbers out of all 11 hospitals? Is that what you were saying, not just KU?
You're breaking up so much, I could not
Kelly.
understand it.
Kelly, this is Jill. Can you put the phone up to your mouth a little closer?
I think I am. I just wanted to clarify that those numbers that you gave are the total from all the 11 hospitals, not just KU.
The numbers that we gave around capacity and the numbers that we gave around the current number of COVID patients in the hospital today were from the 11 hospitals. So not just KU numbers.
Okay, one more question.
Hi, I'll ask a question. This is Emma James, 41 Action News, about elective surgeries and kind of the backlog there that could potentially cause with canceling or delaying those. How was it last time dealing with that? And can you just speak about kind of the long-term issues that could be if you are having to delay those?
You bet. And bless you for asking that question, because that's a big deal to us. So, you know what, it was hard getting it back on. First of all, people get scared. They don't go get care. And what we know, and they don't get care, is delayed care is bad care. For example, when patients thought it wasn't safe to go in the hospitals, they would have chest pain. There was a heart attack. They wouldn't come there. And what we're seeing now is people with complications of heart attacks that occurred in March and April when they were afraid to get here, or they thought they should delay their care. Same thing's true of stroke. That is a bad outcome. Waiting for somebody who needs a heart surgery or cancer surgery, man, you start delaying that, and you make people afraid to come in, or you delay breast cancer surgery. That's a bad outcome. So we know it's more difficult to successfully treat a disease the longer we wait. We really don't want to do that, and yet those are the type of choices we'll be making. Let me talk. Mark Steele at Truman. What are your thoughts about this question?
No, I absolutely agree with you. And obviously, we don't want to delay things like cancer screening. And as you pointed out, that a lot of these surgeries are not entirely elective, and they're things that are necessary care. And so when we did that before, we obviously did have a backlog, and we were able to eventually work through that. But I think, and even from the clinic side, the medical side, and taking care of folks and making sure they're managing their diabetes and any chronic conditions, and we saw some people who ended up getting sicker than they should have if they had been having that care regularly.
Larry, thoughts at Shawnee Mission, same kind of thing?
Unmute myself. Yes, I agree with both of you. I think we did have a backlog. It was a little bit of an issue to get to be able to bring that up to speed. But I think the delay of care in some of those patients, never necessarily having to do with surgery, but the other types of patients, the diabetes, the heart disease, those were also impactful, and we really would not like to see that happen again.
David, it took us about 3 months to work through our backlog, I think. Is that about right?
That is about right. And I think we ended up making sure that about 75-ish% of those surgeries that were delayed got taken care of. Many of those others may have either decided not to seek care or have gone somewhere else. We're not quite sure. But yes, it took us months to do that. And while we've talked a lot here about the implications on patient care, which are very real and probably the biggest driver, I don't want to forget or don't want it to go unsaid that the implications of working through that backlog to try as quickly as possible to manage those that were delayed, the implications on our teams, our staff were pretty impressive. And by that, I mean lots of overtime, lots of long hours, lots of sort of emotional burden that comes with knowing that there are people that you need care that you're really trying your hardest to get to and you struggle or don't get to as soon as you would like to, knowing that impact on their outcomes. So there's a lot of impact from this.
And just to say, burnout is real. It's really very real for our staff. So, and I think for all the staff in our hospitals, and people are stressed.
And I think the last question that we have, you've sort of spoken to it, but yes or no, do go and get health care and do your screenings and go to the doctor, or we should hold back?
No. Go. Because A, if it gets worse, it's going to get harder to get in. And B, hospitals are a safe place. Remember what we said earlier. The hottest spot in any place in the world is a hospital ward full of COVID-19, but we don't see disease transmission because we follow the rules of infection prevention and control. You're safe when you come here. Actually, I'm going to go out on a limb, and I'm going to say, my own personal speculation, hospitals have never been safer because we do such a good job around infection prevention and control. So don't delay your care. But we may have to delay your care if we don't have a bed. And that's a bad choice, right? Then technically you are deciding who's going to get something and who's not. And man, I don't think we want to be back in that position again. That was tough. So I want to thank everybody for listening. We so appreciate your being a part of this. I want to thank all of our chief medical officers who have been such a great source of information and have been on this program with us today. To Raghu Adiga up at Liberty. I know Jim Stewart did the drop off from North Kansas City. Peter Holt I think we had a connection problem at St. Luke's. He's a great person. Mark Steele over at Truman, Larry Botts at Advent's Shawnee Mission, my good friend and colleague, David Wild. We're always happy to try and answer more questions. Help us keep our community safe. Thanks for what you do.